Good day. Let's study about esophageal lymphatics. Remember the tube that brings food from the mouth to the stomach? Yes, the esophagus also has its own lymphatics. It is unique in several ways. Firstly, it has two layers. The submucosal layer, which is bidirectional in flow, and the intermuscular layer, which is circumferential in flow. These two layers eventually drain into the paraesophageal lymph nodes. The paraesophageal lymph node is unidirectional in flow. The upper 2/3 drain upward while the lower 1/3 paraesophageal lymph node drain to the abdomen. So what is its significance when it comes to malignancy of the esophagus? We all know that esophagus cancer's main route of spread is via the lymphatics. That is why surgeons ensure adequate oncologic resection. That means it includes the lymph nodes are removed aside from resecting the mass. The approach and dissection varies depending on the location of the mass. The cervical esophagus spans from the upper esophageal sphincter and cricopharyngeus muscle up to the collarbone. And from the collarbone up to the azygos vein is the upper thoracic esophagus. These segments of the esophagus is treated with subtotal esophagectomy. For this procedure, you would like to access the neck, the chest, and the abdomen. McKeown procedure is a known procedure that provides access to these areas on the following order. Right thoracostomy allows esophageal mobilization and lymph node dissection. Mobilization of the stomach is done via midline laparotomy. Lastly, in the cervical incision is where you can perform the cervical anastomosis. However, for esophageal mass close to the cricopharyngeus muscle for about 3.5 to 5 centimeters, definitive chemoradiation is the treatment of choice. Middle esophagus starts from the azygos vein to the inferior pulmonary vein. Middle third esophageal tumor surgeries include McKeown's subtotal esophagectomy and Ivor-Lewis partial esophagectomy. Ivor-Lewis esophagectomy will require preparation for creation of gastric conduit via a midline laparotomy and esophageal mobilization, lymph node dissection, and mediastinal anastomosis via right thoracotomy. If a less extensive dissection such as a partial esophagectomy is done, a proximal 3.5 to 5 centimeters margin should be ensured for adequate resection and decrease risk of local recurrence. An alternative approach would be a single incision with left thoraco-abdominal approach. However, its shortcoming comes with its inability to access tumor superior to the arch of aorta. Lower third esophageal cancer is complex because of possible invasion of tumor to both esophagus and stomach. The options are Ivor-Lewis esophagectomy, transhiatal esophagectomy with proximal gastrectomy, and transhiatal esophagectomy with total gastrectomy. In deciding for the management of lower third esophageal cancer, the Sievert classification comes into play. Sievert 1 is any mass with epicenter located 1 cm up to 5 cm above the GE junction. These lesions are managed by transthoracic approach such as the previously discussed procedures. Sievert 2 is any mass with its epicenter between 1 cm above GEJ and 2 cm below GEJ. In addition to distal esophagectomy, proximal gastrectomy is done when gastric invasion is less than 1/3 of the stomach. However, for gastric invasion more than 1/3 of stomach, total gastrectomy is done. These transhiatal esophagectomy and gastrectomy procedures are done via midline laparotomy and dissecting the esophagus through the esophageal hiatus. The gastric conduit is brought to the neck and anastomosed to the cervical esophagus via a cervical incision. Sievert 3 is treated according to management of gastric carcinoma. That's all for now, guys. Thanks a lot.